Good morning, good afternoon, and good evening. It is with great pleasure that I welcome you all here today for this webinar on optoacoustic imaging of muscle degeneration and late-onset Pompe disease. My name is Mia Tischler, Medical Affairs Associate of iThera Medical, and I will be moderating the session. The webinar itself will last for approximately 60 minutes, and we really do encourage questions. At the bottom of the screen, you can see a Q&A box where you can type in your questions, and we will answer as many as we can at the end of the session. Please also note that while there is a hand raise icon, we kindly ask that all questions be submitted in written form, simply to keep everything running smoothly and ensuring that everyone's questions can be addressed effectively. The webinar will also be recorded, and we will send you a link to the recording over the next few days. So now I'd like to welcome and introduce to you our speaker of today, Dr. Ferdinand Knieling. Dr. Knieling is a clinician scientist at the Department of Pediatric and Adolescent Medicine at the University Hospital of Erlangen, with a focus on advancing optoacoustic imaging technology and translating it into clinical practice. His groundbreaking work has established him as a leader in clinical optoacoustics, highlighted by publications in the New England Journal of Medicine, as well as Nature Medicine. Recognized with numerous prestigious awards, including the Adalbert Czerny Award, Dr. Knieling's contributions have revolutionized the use of optoacoustic imaging and pediatrics, bridging innovative research one day with routine medical diagnostics. All right, Dr. Knieling, over to you. We're really looking forward to your presentation.
So I go on sharing my screen, and hello everyone, good afternoon, and thank you very much, Mia, for this kind introduction, and especially for giving me the opportunity to present this work. Especially, I'd like to highlight the chance to draw attention to more unknown and more rare diseases as we discuss this today, and I hope that you will learn today. I have the following short disclosure to make, and I'd like to say that this research isn't possible without support and without research grants. And as mentioned in the introduction, today we are referring to this work, to this publication, and if you want to dig deeper, this is publicly available, it's open access. And I'd also like to thank all the people that are on the paper that contributed and all the patients that traveled to our department, helping us to establish this research. Today's agenda comprises the following. We will talk a little bit about the background on rare diseases and medical needs. We will talk about Pompe disease basics, pathophysiology and its treatment. We will also cover basic of optoacoustic muscle imaging. I will show you our study results and have a short conclusion and outlook. And as Mia told you already, we have a Q&A session, and we hopefully have a lot of questions, and you type them in and we have them answered at the end. Before going into deep with Pompe disease, I'd like to set the stage with some general information about rare disease. As many people might already know, a rare disease is defined as a disease that affects less than 5 in 10,000 people. And this is considerably rare, but we have 6,000 of such diseases, or even maybe much more, and it's growing day by day. The most of them are genetic, 72%, and most of them affect actually children, and they start during childhood. So it's really something that affects my daily care. And looking at these diagrams, the awareness has grown, not only the awareness, but also legislation. Nearly like 25 years ago, and if you look at the left diagram, the Sankey plot, the EU recognized it and enacted some regulations that speed up development of treatments for rare diseases and conditions that are not like myocardial infarction, cardiovascular, but much more rare. And you can see the development in the diagram. And we now see much more diverse areas of indications for medicines. And in the same time, on the right diagram, I pointed out, you can see that studies are growing that actually target medicines for people for less than 200,000 patients in a cohort. So these are medicines that are actually targeting rare diseases. So we have therapeutic developments that aim increasingly at diverse areas of applications and target smaller patient populations. But at the same time, I think we are years behind in the development of developing diagnostic capabilities in a broad sense. And in this sense, I try to summarize in this graph here. So diagnostics is not only setting the early diagnosis, but it's also stratification or monitoring of patients. And in case of a rare disease, we might not spot the diagnosis in a phase where we have compensated function and maybe the child is developed normally. We mostly spot patients when the disease is already symptomatic and when there's some kind of organ dysfunction. So we desire diagnostic tools that are earlier and that give information earlier and more sensitive. So I think in that odyssey of diagnosis, and this is what patients actually tell you, we definitely need these diagnostic tools. More closely looking at imaging, and this is what we are talking about, and we are more closely talking about that first line here, that's OAI, that's optoacoustic imaging. We think, and I think, optoacoustic imaging provides really benefits for patients that are severely affected by a disease, especially in terms of providing very diverse morphology, functional molecular information, but also in terms of safety and usability, but also in terms of image quality. This does not mean that MRI or other modalities provide very, very precise and useful information, but simply this underlines that bedside imaging, especially provided by optoacoustic imaging or ultrasound, is very useful in such patients. Why this is so important, I try to illustrate you in the next video. The next video shows a patient which we have followed over a year. And in this video, he's just simply given the task to raise his arm above his shoulder, which is obviously not possible. And if you look a little bit more closely, you can even spot his father at his back, holding him up straight so that he can sit in a stable position. And this explains you a little bit the disease, because it's a proximal muscle disease and it's really severely affecting him. Even it has not begun as a very, very small child, it can progress in very diverse ways. And this is what I try to explain you today. So Pompe disease, as we said already, is a rare disease. We may have around 250 cases in Germany, and it's genetically inherited, it's autosomal recessive, and the defect lies within the lysosomes, and there's an enzyme, it's called acid alpha glucosidase. And this enzyme usually breaks down glycogen into smaller molecules, which are then glucose. And these, as you already know, provide energy to the muscle. And this energy deficiency, but more importantly, also the excessive storage of glycogen in lysosomes, leads to the disease pathology, especially to a proximal muscle weakness. And the muscle over time is then replaced by other tissue, especially by fibers such as collagens, but also by fat. And it's getting dysfunctional, and the result is very diverse. But it's not only affecting the muscle, it's also affecting other tissue. But what we are looking at today is especially the patterns in muscle. So as I told you, and this in more darker color, you can see here, the more affected tissue is actually the proximal tissue, and it's getting more lower affected grade the more distal you go. And there are studies out there, very nice studies, especially MRI studies here from Jordi Maneas-Diaz group, and they looked at these patterns in MRI, and it looked in all the different muscles. And what they can see is that there's really a proximal to distal pattern. And so you see more affected muscles, which are darker in that score, and less affected muscle here in the distal areas. So this pattern you can also see in the imaging, but it's also giving clinical. But this is not also the only pattern you see. It's also a different types of disease coming with Pompe disease. So you have an infantile onset and you have a late onset. Per definition, infantile onset is within the first year of life. And these patients, usually seen in the neonatology units, they're affected by cardiac hypertrophy, severe muscular hypertony, and they have a really limited life expectancy without treatment. Usually their enzyme activity or remaining enzyme activity is very, very low or even completely missing. And this is in contrast to something we talk about today. It's late onset Pompe disease, which is by definition after the first year of life. And these patients have very diverse enzyme activity maybe, and very diverse genotypes sometimes, but they also experience muscular hypotony. And one leading cause of problems in their life is respiratory insufficiency. So very proximal muscles like the diaphragm. Life expectancy can be decreased, so 30 to 50 years, but it really depends on enzyme activity, and sometimes it can be also slowly progressive. Pompe disease has experienced, as I've shown you with the EU legislation, a growth in therapeutic options. One major therapeutic option is ERT. This is enzyme replacement therapy. This is the standard therapy already. And as you can see here, we already have second generation ERT already approved in the EU, and a lot of patients are now switched to these medications. And they're affecting, especially in infantile onset Pompe disease, where they really save lives. This is a game changer here. And also effective in late onset Pompe disease, where they can stabilize or even improve walking distance or respiratory function. But also, and this is really nicely summarized here in that new paper, you can see there are diverse areas where there's research and where there's also hope that we get a lot of new, very innovative medicines, which may also improve the function of these patients. And this can be gene therapy or even mutation-specific therapies, which are still in preclinical development. But we can talk maybe an hour about this. We want to more closely look at imaging. And this is where we switch to optoacoustic imaging now. So optoacoustic imaging has maybe standing in between role, I would say. So it stands in between preclinical imaging modalities that provide really high resolution, but which don't go deep into tissue. On the other hand, there are clinical imaging modalities providing volumetric information, but they won't go in high resolution maybe. So optoacoustic imaging is maybe bridging these two worlds, and it provides a considerable depth for imaging, but also a high density of molecular, maybe subcellular information. The technical principle behind optoacoustic imaging is that you use pulsed laser light. This is emitted into tissue, so light in, and this light produces thermoelastic expansions in molecules depending on the wavelengths you emit into the tissue. And what you get back is actually acoustic pressure waves. As I said, depending on the light that you use, you will get different response from different molecules. And if you use multiple illuminating light from a pulsed laser light, for example, you can then go back and with a spectral unmixing, and you can maybe then calculate out which components are present in tissues. Maybe hemoglobins, the oxygenation status, water, lipids, and other components. We have shown this already, that this may work in Duchenne's muscular dystrophy, but also in SMA, spinal muscular atrophy. And I'd like to show that this is maybe also promising in Pompe disease. What we first did, we actually asked the question, would we see an absorption profile of glycogens in a spectrophotometer? And what we have seen is that it's actually hard to distinguish, that there's not a specific peak which you would get from glycogen. And usually you would see a specific peak, but what you see here is maybe flat lines. This is photometric information. We did the same experience more or less. We built phantoms and tried to image them in a clinical imaging system. So that's the acuity imaging system, and with a handheld device. And we developed, and I go into deep in the next slide, a phantom, and we tried to image what would we see if we increase glycogen concentration in such phantoms. And what we have seen is that we get some kind of peak. But this peak, we think, overlays a little bit with the water peak. And this is why we think that glycogen is maybe not really directly detectable, but it has something to do with the presence of water, which is maybe the effect of the accumulating glycogen. So we kind of try to mimic this more closely to a realistic scenario. And this is why my colleagues, and this is developed by Roman Ramming here, one of the authors of our paper, he printed like a mold, and what he put in is minced meat. So he wants to mimic really a biological muscle and not a static phantom of like artificial components. He really used like minced meat. And this minced meat was then mixed with different concentrations of glycogen. And what you can at least see a little bit, if you have really excessive glycogen, you kind of get a peak. And now the question was, do we have similar effects in the patients, and can we kind of see such effects in patients that are maybe severely affected? And that's why we actually recruited patients. This was considerably hard to do because this was during the time for coronavirus lockdown. So we had a really long recruiting period, and we had a really struggle because these patients are also a risk collective for like pulmonary infection. As I said, they have impaired lung function maybe, so you don't get them into risk. And this is why this took a little bit of time, but we finally got all over our country, at least, patients that traveled to Erlangen and got imaged in our facility. And we matched 10 healthy controls. And we did all of like standard diagnostics. And we had 20 patients completed the MSOT, and also 20 patients completed an MRI of the muscles and ultrasound, and also a lung function test, which is a standard for these patients. And here's the patient characteristic. As you can see, they're more or less comparable by age. So it's around 40 years, but which is not comparable is maybe age, weight and something, but this is really explainable by the disease. What you can see already, and this is also in the table, but also in the graphs here, that vital capacity or like basic muscle function is severely impaired in some patients, but there's also heterogeneity. Some patients might not show really a clinical sign. Some show very much clinical signs and very severely impaired function. So there's a lot of heterogeneity in these patients. So this is some examples from our study. This is grayscale ultrasound that you may get from a routine machine. This is from the Acuity MSOT system. It's similar produced. It's a basic B-mode ultrasound, more or less. And here's like the muscle of a healthy volunteer. And this is, and maybe if you look very closely, you can see that there's a change from mild to moderate to more severely affected patients. And if you look very closely, you can see in the severely affected patient, this muscle looks very much different. And if you look a little bit more closely, and I brought a video which we just made from our new MRI facility in our pediatric department, which I think is very nice, and the MRIs of such patients. And the MRI is really an established method which has progressed like the really recent years with different techniques to show the effectiveness of the muscle in these images. And what you can see here is that especially in highly affected patients, you can see that the dark muscle tissue is replaced by other components which are really also fat and other components which make them really dysfunctional. But, and this is interesting, we did not find all patients with an increased fat fractions, for example. We only had one patient that had an increased fat fraction in MRI. And we ask ourselves, okay, is this not a good method? And it is actually a good method, but what we looked at was the biceps muscle. And I show you here from this nice study again from Jordi. And he showed already that if you look at biceps muscle, MRI won't show you will show you the same result actually. It's only very few patients that are severely affected and show an increase in the MRI score. And the more distal you go, the less affected muscle you will see. So maybe a more affected muscle is more proximal, but this was clear. But we wanted to show, can we see a difference in this biceps muscle if you look at optoacoustics? And optoacoustics is done very similar to ultrasound. That's why we again made a video to illustrate you a little bit more closely how this is done. And you can see you have this scanning probe, and it's, as I said, comparable to ultrasound. You can even see the light here in that video, how this is shot at the tissue, and you can see the live mode of the image. You can see the skin line, and below you can see the muscle tissue. You can even see the bar here that shows is the probe moving or not. Is this a stable image? So Roman is here moving around and scanning our subject here in different positions. So it's considerably easy to do. It only takes a few seconds, and then you would get the first optoacoustic images. And this is what I like to show you here. And again, we plotted you a healthy comparison and compared it to mild, moderate, and more severely affected patients. And what you can see here, at least for the algorithms we use for reconstruction, that the muscle signal in a healthy subject is usually really broad, homogeneous signal, as you can see here. And this is made for 800 nanometers. And at 800 nanometers, I don't show you the graph again, but what you will find here, that you get a lot of absorption by hemoglobins, but also myoglobins that are present in muscle tissue. And what you also can see going from this top end to this lower image, that the signal level for this myoglobin, hemoglobin signal is dropping in this more severe affected patients. And this kind of is really interesting because it says maybe that the functional tissue is decreasing. And I made this a little bit bigger to illustrate this a little bit more clearly. So I think there's really a clear difference between a healthy subject and a really severely affected patient. And we also calculated these other components which come by the other wavelengths, which you can use for spectral unmixing. And you can also see that the signal levels may change regarding the component that you want to unmix. And I show you this maybe for lipids. And as you can see here, this is a healthy subject. And here is the more severely affected subject. And I think you can at least estimate that there should be, or there is quite a difference in these subjects. And we took that signals and correlated them to our imaging findings and also to our clinical findings. And I think this is really interesting because MSOT parameters, such as the lipid or collagen signal that is derived from the MSOT signal, that correlate, for example, with lung function. This is functional vital capacity. So it says the more functional vital capacity you have, the less fat you have in the muscle, the more functional tissue you have. So I think this is just from thinking, this looks straight, but it's an interesting correlation which you may clinically use. And it's also true for other measurements, and you at least see some correlations for this few patients. More closely, coming to different muscle groups, I'd like to show you some different sections from different muscles. So this is, the first image is paraspinal muscle. So it's shown with the first bar here. Then again, biceps, and again, forearm muscle. And as you can see here, the images look a little bit different because the muscle is always a little bit different, but at least you see a little bit of a gradient here. So you see maybe in the paraspinal muscle, you see here some signal, while you see in the patient not so much signal. From the biceps, we know already there should be a difference. This is again 800 nanometer. And then the forearm flexors, you also see some difference. And I think this is a really, really interesting information, because at least we can differentiate some degree of affectance in the distal muscles. And I showed you this was not possible, at least not in every MRI study. And if we take the entire spectrum, you can also see that some kind of peaks we found in our preclinical models is present here in the proximal muscle, and it's maybe much more prominent, but it decreases to the more distal muscles, which is matching the clinical phenotype at the end. So this is just to recall you. So we looked at the biceps. We also find like these few patients that have an alteration here. And for the MSOT, maybe we cannot detect a lot of patients that have alterations here, but we can maybe also see them in these muscles at least a little bit. And this is where the MRI also may have problems. As you can see here, that actually no Pompe disease patient has an increased MRI score in the distal muscle. So at the end, I'd like to come to some data that tried to show in that paper some kind of multi-center validation. And I'd like to discuss this a little bit longer, because I already had questions, and I like these questions that were sent directly, because the kind of question, is these data really showing a validation? Because they look so different. And I think this is a really important point. And what we can see here, that we, at least from two investigators, we kind of get similar curves. And from two centers, we kind of get similar curves. So that's the entire spectrum of a muscle, but they also look a little bit different. And this is a really important point, that we really need a similar approach across centers, and that we also need some kind of validation across really more subjects and more centers and more machines to say that we are really valid with what we say. But at least we can say that we have some similar effects. To demonstrate this, we made a little bit more deeper analysis, and this is showing the next graphs here. And we analyzed the signals we found increased. So this was collagen and also lipid signal. And what you can see here, so in the first center, so in our center, and also in the other center, this was the University Medicine Center of Göttingen, they also find the signal increased in patients when they are compared to healthy volunteers. But what they didn't find increased is the lipid signal. And as you can see, at least in our patients, there's a huge broad distribution in lipid signal. So I think this is already an important point. So we need to address, where does this heterogeneity come from? And one point for heterogeneity is the patients, as I told you already. So they are very different. So every single patient is a very different patient. But the other thing is, what does the investigator do and what does analysis do? So, and this brings me a little bit to my conclusion here. And I would say that MSOT is safe and applicable in Pompe disease patients. And we think, and we really think, involvement is detectable in distal muscle groups. And this is really promising for such patients, because this does not pose too great hurdles for them. They don't need to go to a very complicated investigation, or if they are already on ventilation, for example, you may really have struggled to get them in an MRI. And what we could show is that MSOT correlate with standard reference diagnostics, such as lung function, such as to some degree function as walking, or also other imaging modalities. And the origin of the signal we see is possibly to increased glycogen-bound water, but I think more work is needed here to substantiate this, but at least we found some explanation in our model. In the further course, we would like to see that also infantile onset Pompe disease patients may profit from some technologies, and we have approval right now for patients that are below, that even go down to 2 years of age. But we think we should try studies in even younger patients because we think they have much more significant changes and they profit much more from the therapy. So monitoring their effects should become possible. And follow-up work is needed on other anatomical regions, more proximal muscles, as I said. And also we need to address disease heterogeneity. And we think longitudinal studies are possible. And this maybe is the first way to see if there's a possibility to monitor some kind of effect that is either posed by the progression of the disease or either by the therapy or other influences. So with that, I'd like to thank you for your attention, and we hopefully get a lot of questions. And I'd also again like to thank iThera for bringing this onto stage, also for all the patients. And I'd also like to thank all contributors again and our supporters for this study.
Brilliant. Thank you so much, Dr. Knieling. That was an amazing talk. I can already see that we have some questions coming in that are very interesting. But just so you know, if you have any additional questions as the discussion continues, please type those into the Q&A section as well that you should see on the screen. And if we cannot get to all the questions that you have, don't worry, we will respond to every question on an individual basis after the webinar, though. So, Ferdinand, maybe we can start with some general questions. In the beginning, you showed a slide about different types of depth limitations for imaging tools. And so someone is asking, well, how deep can you actually see into the tissue?
Yeah, this is, I think, the most important question right now. And we think we're at least confident to see 1 to 2 centimeters. That's why we actually picked the biceps muscle, because we know that subcutaneous fat is not that big issue at this area, and we struggle much more at other areas. That's why we still lack a little bit in time for these other anatomical areas. We may go deeper, but this is also maybe a challenge for, like, in terms of technical applications, also software applications, I think. But rather from the technical side, I would say it could go much deeper. But realistically, especially for types like muscle tissue that pose really high signals, you would get signals at 1 to 2 centimeters, and they really pick up all the signal. And then behind this, it would be really hard to see maybe the bone, for example.
Okay, so there is another question that ties into this one, I feel like, because you spoke about the differences in weight of the patients you imaged. So someone is asking, what factors do you need to control or consider when preparing for conducting the examination? So to speak BMI and such.
Yeah, this is definitely a factor. So one thing is that you need to prepare for the study. This is one thing, but I think this maybe targets a little bit to analysis. and this is also something we ask ourselves all the time. And what we have done at the moment is like trying to get similar depth and like measuring when the muscle starts, something like this. But what we need to get and what we are working at is maybe getting a more objective way, which means, can we develop something? And I think this is already underway. I can tell you that we can segment the muscle and that we can analyze maybe something which is more or less automatically detected, which is a little bit more objective. But in terms of technical conditions, I would say if you want to look at something which is below like 2-3 centimeters, I would not go for it at the moment. I would rather look at really things that are ideally like 1.5 centimeters in that area. And you want to make sure that not large vessels or any other dense things that also pose maybe a obstruction also for ultrasound, like air or something, are not in the way of the signal. And I think these are the precautions. In terms of BMI, I would say yes. Especially if you look at fat signals, like 930 nanometers, this is something you need to closely look at if you get a lot of differences.
You spoke a lot about MRI and results and showed the nice room. And so I think the next question is kind of relevant, ties into that is, well, how long does an examination take with an MSOT device in comparison to other imaging modalities like MRI?
Yeah, okay, this is a nice point for MSOT, I think, because typically speaking, and if you're familiar with ultrasound, this is like one-to-one comparable. So this is like an ultrasound, depending on the areas you want to look at. Maybe if it's just not the biceps, this takes you rather like 2 minutes or so, because the scan itself is like 10 seconds. Preparing everything, and you all know that, and it's only a few minutes, yeah. But typically what you do with ultrasound is that you are flexible and you can look at like very diverse areas, so your examination can easily take up 20-30 minutes, especially with such patients if you want to reposition them. And this is a little bit the difference to the MRI. I don't think that the MRI takes very, very long. They have really short and really precise sequences. But a little bit the logistics, I think, are the point. So bringing a patient in with saying like a ventilation or something, which is true sometimes for late onset Pompe disease, it's a huge problem for some MRIs. Yeah. So I think bringing someone in there, someone who may not be able to lie down very easily because he can't not breathe very easily. So
Yeah.
this is a huge problem. And an MSOT you can do like in any position you'd like to. Yeah.
So when we speak about workflow and how it all works, someone's interested in hearing your comment about operator variability, because you also mentioned that in the end.
Yeah. So we conducted a study abroad. Actually, I don't know if we need them, if this is too much, but we did investigate this way before we did all these studies and looked how precise could we do this, and tested different operators and different trained operators. We even last year did a study where we tried to find out how long would it take to train someone. And we think in terms of muscle, this is, let's say, pretty easy to do because the muscle is the easier target in optoacoustics, as long as it's not severely diseased. Because if it's healthy, it gives you a really clear signal. If it's not healthy, it gets a little bit more complicated. But saying this, if you like, and this is what we do, we really have fixed positions where we scan. So we measure more or less and say we do a cross section at that height of the biceps or at that height of the gastrocnemic muscle. And if you do it like this, you get really comparable results. And then your difference of a measurement is way, I would say, below 10%, depending on the parameter you measure. So we know already that lipid parameter is a little bit more variable than other parameters, but a single wavelength is very comparable, say, over different assessments, even repeated assessments, and even over a shorter period of time. And I think, and this is what iThera is also working on, the question will arise when it comes to much, much longer studies, saying over years, and how would we control for this? I think the what you need to invest to plan such a study is a little bit more than just repeating a similar scan.
Maybe to come to the last general question in terms of workflow, if someone asks how many passes would you recommend to go over each muscle group?
What do you mean by pass? So how often we would repeat a scan, you mean?
I suppose that's what they mean, yes.
Okay. Yeah. So what we typically do, we do at least 2 to 3, but what you actually get when you do a MSOT scan is a bunch of images. So if you record 10 seconds, then you get like multiple images you can analyze. And usually the analysis, how it's provided today, is done more or less as a mean of multiple frames you already captured within this time frame. So you already get a mean of multiple images. So what you get is a lot of data actually, but what we do is do at least 2 to 3, and then we compare these 2 to 3 and do mostly like the mean or whatever of these two, or have at least one to reject if we think this is completely meaningless. But I would recommend to do at least 2, as we do it for most other studies like duplicates or triplicates. But remember, you would get a bunch of data already with one scan.
Yeah. Maybe we can come now to probably the topic that most are or have the highest interest in. It's really the ERT part. So we have multiple questions that come down to the same question, really, is well, do you foresee that MSOT, so this technology in itself, could be used as a screening tool for early detection of treatment response? So this was the question. I suppose they mean ERT, obviously, in this case, but yeah.
I would also foresee that this is really important. So coming to this, we have thought a long time of what is the application for MSOT in such a scenario. So is it really therapeutic monitoring, or is it something else? But really the same thing comes to your mind. So it's maybe therapeutic monitoring. And if it's in terms of ERT, and we discussed this in multiple panels, and giving my personal view and my view as a pediatrician, I would say I would like to see the response at least in an infantile patient. So this is where we think the most happens. So if you ask the colleagues that are very experienced with these patients, they say if they just look at it, there's a huge difference in the muscle, also on the ultrasound, what happens within that first phase of treatment. So I really have a problem to foresee what would happen if we initiate a therapy and look pre and post. And this is really a struggle we have, because we won't have enough patients that like don't have a therapy right now and which we can then monitor in the future. Because the logistics for such a study is very complicated. So
yeah,
I think this would be rarely decided, and I would really like to conduct this study, but it's like really complicated. And if we want to do treatment monitoring, and I really teased this a little bit before, and the problem is I think also a technical problem. So this will be monitoring over years, and this is also other, I think, topic of research where we need to at least ask the questions: how can we standardize our measurements over this whole period of time? So saying, is the laser having the same power? Is the quantification we are doing the same meaningful for day 1 as it is for day 1000 or so? So I struggle a little bit with this question. I'd like to maybe point in another thing that I find important, is that can we actually find patients that would benefit from a treatment? And I think that is something which is important, because at the moment we would start patients with a clinical sign of disease, and this like clinical sign of disease is very subjective sometimes because what is a clinical sign? So is it muscle weakness, or is it being slowly, or is it showing an impairment in breathing already, or could it be something else? And if we say we can image that there's impairment in the muscle and we see affected distal muscle or like affected XY muscle, is this not a sign that we should consider treatment? And this is also application where MRI is already discussed, I would say. And maybe this is something we should start with these patients that are pre-symptomatic, we say at the moment. Wouldn't they benefit from being treated early if they also have like a suspicious MSOT?
Well, someone's asking in more depth, what signal do you believe will be most sensitive to the treatment? So some type of glycogen signal, 800 nanometers, fat collagen, question mark. So
yeah,
it goes hand in hand what you said, yeah.
Yeah, so I think it's complicated. So depends a little bit also on the phase where we image, right? So if we say we image a patient that already misses a 800 nanometer signal, which we at the moment consider as like a muscle signal, do we really think that a ERT treatment is regenerating the muscle and we would pick up that muscle at later stage? I would say maybe complicated. So it's hard to say, but if it's an early phase, I would say like a more general muscle signal is at the moment very, very stable. Like 800 nanometer is for us really nicely working. It's as we know, very repeatable. This could already help, and this is easy to do because it's only a single wavelength. And unmixing is really a different term. So maybe we are not at the end of the pipeline we have, because there are much more parameters we can use. So we can even say, we can do a functional assessment. So we can even ask the patient to challenge and maybe to do a small exercise and measure before and after. Maybe this is giving us much more information about the functional capacity of the muscle. And maybe this is much more meaningful for treatment. So I would say we are still not at the end of the line.
Okay. So I'll ask one more question and then we would conclude the webinar. And the last question is, so the study suggests that you can primarily see the glycogen-bound water and other components. So what other substances could theoretically be detected using the technology, and what would you be interested in seeing in terms of other components?
Yeah, I think we are already there at critical points, discussing with our colleagues from the muscle MRI field, because I think one major component, and this is what we proposed some years ago, is that this is maybe collagen, which is also complicated, I would say. But this is a component, if we can make it more clearly and distinguish it more clearly, maybe, for example, from a water signal and something. And this is a really important component, and this is something new, especially if we compare it to MRI, because it's also hard in MRI to do this. So and we just think this might be earlier than the fatty replacement. So in the cascade of the muscle degeneration, we think that there's an accumulation of the glycogen, then there's still like glycogen and some muscle tissue, but then you get an increase of fibrotic mechanisms. And then in the end, you get lipids, so you get fatty replacement. That maybe kind of the easy sequence, you would say. But this is like one part of the story, but the other part, and this I said already, is these functional parameters. So what I would like to test is what kind of metabolic information could we get out of the muscle tissue in terms of oxygenation consumption, for example. And I think this is maybe much more related to the function. And this is something we actually should do and which is already done in some other indications. But for these patients, it would be also very, very interesting, I would say.
Yeah, I agree. We hear that in the field a lot. Yeah, that was very interesting. So thank you so much for your time, Dr. Knieling, taking the time to present the research, and for the Q&A session. We really appreciate it, and we'll be in touch over the next few days with the attendees with the recording. And again, thanks so much for your time and attendance. Yeah, goodbye. Have a nice evening.
Goodbye.